I'm going to talk about non-union fracture neck of femur in elderly. And you heard Dr. Magoo, and he said if an old person comes, you just do an arthroplasty. So let me take a case for it. Let me make a case for it. So these are the learning objectives, and let's address them one by one. So the fracture neck femur, you know, is a very common, in fact, the second most common osteoporotic fracture, and there are about 1.6 million fractures worldwide annually. What is a non-union? It's very difficult to define it. And then the definition varies from unoperated to operated. So people have said from 3 weeks to 6 weeks to 3 months as ununited or untreated if the fracture neck femur has not been operated. And today I'm going to talk only about the unoperated as the topic suggested to me. So we would usually take it about 3 weeks, especially in an elderly. We have low threshold of doing the arthroplasty. The incidence overall for non-union for fracture neck femur is 20 to 33%. And undisplaced fractures, it's up to 5%. And in displaced fractures, it's 9 to 35%. You must always try to remember the anatomy of the neck of the femur as well as the vascularity. The capsule encloses the femoral head and most of the neck except posterior lateral aspect. And no callus is formed in the intracapsular part. We'll talk more about that. And then always remember, you know, the femoral neck, scaphoid, talus, you know, these are the areas where you must always remember the blood supply, as also the collateral vessels around the elbow and the knee. Now, there's an extracapsular arterial ring. The ascending cervical branches rise from lateral epiphyseal artery, 80% supplies because of that. Then there's artery of the ligamentum teres, and fracture neck of femur jeopardizes the lateral epiphyseal vessels, and then the intracapsular tamponade is the one which is the culprit. Now, the Dr. Sandhu has published a seminal paper on the staging or classification of neglected neck of femur. It will help if you study that. It is based on 4 factors which can have a mnemonic gaps. So gap between the fracture fragments, AVN changes, proximal fragment size, and surface of the fracture. And this is a chart which helps you to decide the plan of action for a patient who comes to you with a fracture neck of femur. Now, change in the non-union. The changes during non-union which occur include absorption of the femoral neck, which leads to reduced size of proximal fragment. The fracture surfaces become smooth, the fracture gap is increased, and there are avascular necrosis changes in the femoral head. There is thickening of the synovial membrane and joint capsule, osteoporosis, the upridden greater trochanter giving rise to limb shortening, and the quadriceps and the glutei wasting. The causes of non-union also, you must know the absence of the cambium layer in periosteum. There are certain cytokines in the synovial fluid which inhibit callus formation. The fracture hematoma is washed away by the synovial fluid, and there's a direct tamponade effect. So also interfering with blood supply. The history includes a definite history of trauma, unless it's a pathological fracture because of malignancy, the inability to bear weight, limp and shortening. There is external rotation, upridden greater trochanter, and adduction deformity. You should look for ASIS deformity levels. Many times these patients with neglected fracture neck femur, when they're lying at home, they lie down on the lateral position on the contralateral limb, because the ipsilateral fractured limb is painful. So they very often develop a flexion, adduction, and internal rotation deformity, and even a flexion contracture of the knee. So beware of that, and also look at the knee if you are having a neglected fracture. There could be a scarpa triangle tenderness, though it's very uncommon in a non-union or a neglected fracture. And all of you must know about the Brandt's triangle, which shows the supratrochanteric shortening. The telescopy is quite likely to be elicitable in a resorb neck. And of course, the Tenberg sign, which has been so nicely demonstrated by Dr. Sudhir Kapoor. There's a Dassault sign, which means that if you try to rotate the thigh, if the femoral neck is intact, the rotation will occur at the pivot around the hip joint. So the femur, the trochanter will rise from the bed. On the other hand, if there's a neck femur and you rotate, it will just rotate along an axis passing through the neck. The investigations include the X-ray, CT scan, MRI, DEXA scan for osteoporosis workup, and the DVT scan, as the patient can be immobilized for a while. And it is not infrequent for us to find patients coming to us when there's a neglected neck fracture to come with a DVT. So the X-rays should be taken. Recommended is the pelvis with both hips AP view, then involved hip with thigh AP and lateral view, and X-ray pelvis with bilateral hip 15-degree internal rotation. So you can actually skip the top one and just take X-rays with the internal rotation. That will suffice. Now the CT scan in a younger patient, when you want to do fixation or osteosynthesis, will be more useful to look at the morphology, and similarly MRI is more useful to see the AVN changes. But then in an old patient, if you have a strong suspicion of a pathological fracture, you may need it. Now the treatment is aimed at providing painless, mobile and stable hip to the patient. And like I said, the replacement for the elderly patient is the treatment of choice, and let's see why. If you have a non-union of fracture neck of femur, with the pre-existing hip disease, this patient had a tuberculosis of the hip joint in the past and had a fracture, and 4 months back was bedridden, came to us with a hip which was arthritic, with a fracture neck femur, and avascular necrosis of the head, and a DVT. And obviously, there would be no controversy about doing a total hip because the acetabulum is already arthritic. But then, if you don't have a hip arthritis and you have a non-union in an elderly, not Dr. Maggu's patient group, there are arguments for arthroplasty rather than osteosynthesis, because you can mobilize these patients early. You don't have to put them through restriction of weight bearing. They can immediately bear weight. The low revision rates are there. The rate of reoperation following internal fixation of femoral neck fractures is relatively high. And the rates of osteonecrosis and non-union treated with fixation is very high. And then the relative risk of revision surgery after arthroplasty is relatively low, particularly in the old age group. So this is an article in Journal of Orthopaedic Trauma, which showed that after internal fixation, in patients over 50 years of age, there was a 21% reoperation rate. And only 67% of all fractures healed at 24 months, and 30% had fracture shortening of more than 5 millimeters. And you can understand that this is really not an option for an old patient. So this is a paper which says that elderly patients with femoral neck non-union, the acceptable revision treatment method is arthroplasty. Right? There is no question about it. There is debate about THA versus HA, and I'll address that. So what about what to do? Unipolar, bipolar, total hip replacement, dual mobility. So let's take a look at it. The fracture neck femur occurs in a patient who has not had arthritis. So the capsule is pliable with age. In an arthritic hip, when you do total hip, the capsule is fibrotic and thick. So the risk of dislocation is very high when you do total hip in patients with fracture neck femur. So you have to try and give either a large head with a unipolar, or an effective large head with a bipolar, dual mobility, or a large head total hip replacement. So hemiarthroplasty is used when the patient is more than 75 years old. Mind you, most of it is physiological age, and also sometimes this 75 can be made 70 years, but the patient should have an expectancy of not more than 5 years. So somebody who's 85 or 90, I'll have no hesitation in doing an Austin Moore, because that will be very quick. And the patient is unfit for osteosynthesis or THR, again, a quick surgery like hemiarthroplasty can be done. So what about hemi? Should it be unipolar or bipolar? There's no consensus, but then it is said that if the patient is older and only homebound ambulatory, then you can do a unipolar. If the patient, and of course, patient is less active or has shorter life expectancy. On the other hand, with the relatively younger elderly who are active, who are community ambulator with considerable life expectancy, you can take bipolar. There's a theoretical advantage of bipolar over unipolar, that there's a greater range of motion before dislocation, and the intraprosthetic articulation decreases the acetabular wear by shifting some hip movement. But there are a lot of studies which show that the bipolar because of the serum and blood getting into between the articulation, can become a unipolar after some time. So this is an 82-year-old male who was treated with an osteomore, and this is a 72-year male who was treated with a bipolar implant. Now, if a patient can afford it these days, my first choice will be to do a modular bipolar, where if required, if there are any acetabular changes later on or issues with the acetabular side, I can go and take out the bipolar head and put in a total hip replacement. Now, the total hip arthroplasty is indicated if the patient's physiological age is more than 60, but the patient has high demands. And it is also the treatment of choice for failure of osteosynthesis of a fracture neck femur, or I know it's very rare, but if Dr. Magu's surgery fails, or if the acetabulum has orthotic changes. There is a very good functional outcome. There are a lot of literature till date, except for very, very recent literature and meta-analysis, which have showed that that only THA should be done, and most of it is from the European and the Western literature, because it causes less acetabular erosion. A lot of people say that it's an unphysiological articulation between the metal and the cartilage. However, there's an increased cost, increased magnitude of surgery. It needs more training, more inventory, increased blood loss, increased early dislocation rate. You have to be trained to do total hip replacement. And then our patients who are in district who get fractures, an average orthopedic surgeon can do a hemi replacement in a district hospital, but it will be difficult for him to do a total hip replacement. And above all, many of these patients we know die within 1 year. It will be too much of a surgery. So unless patient is very young, physiologically fit and demanding, you should consider it with caution. The treatment options, whether this whatever we are going to put in hemi or total is to be cemented or uncemented, is also decided by the DOR femoral bone classification. You must always know that. The A type is the champagne flute, and the C type is the stovepipe, and the B type is in between, depending on the size of the medullary canal and the thickening of the cortices. The advantages and disadvantages of both: the uncemented can be implanted very fast, and there are less risk of the thromboembolism. However, there is a reduced osseointegration, osteoporosis, and risk of fracture is there. The canal may be very wide, and there may be implant size mismatch, and there can be higher pain and less early mobility as per some reports. The cemented one has advantages that you have a relatively lower risk of fracture. It's good for osteoporotic bone, suitable for wide canal, lesser pain, immediate mobility, early mobility, but then there's increased duration of surgery, increased risk of thromboembolism, higher mortality, and also theoretically a higher risk of infection. So this was a 66-year-old female, good bone quality. It was reasonable, even if the neck was resorbed, it was reasonable to do a cementless total hip arthroplasty. So what are the surgical challenges? The bone is osteoporotic. There's a risk of intraoperative fracture. Up-return greater trochanter has to be brought down. So the releases have to be done. Adduction deformity may require adductor tenotomy. You have to pull it down to maintain the limb length. The cardiopulmonary complications during cementing. Offsets have to be restored as per the opposite side. And then, of course, there is risk of dislocation following arthroplasty. So choice in THA, like I said earlier, is effective large head to overcome the high risk of dislocation. This was when we were doing the metal on metal. So this was a non-union fracture neck femur treated with large head metal on metal. I would not do it now, but then there are still options like delta motion, which are large head ceramic on ceramic, which can still be considered in a relatively physiologically relatively younger patient. Now, this is what I want to tell you. This is a dual mobility cup. They come in both cemented and cementless versions, and they allow you to put a total hip and still have a large head, which allows, it's a tripolar cup, which allows movements at the two articulations, and that actually really is associated with a markedly reduced risk of dislocation. And this is my choice if the patient is affording for doing total hip in a patient with fracture neck of femur. Now, long-standing cases with resorbed neck sometimes need special options like a modular neck, and you must keep that in mind. And the post-operative rehabilitation is early full weight bearing to reduce complications. We must try to reduce the further falls at home. And then, of course, the chest physiotherapy, incentive spirometry, active quadriceps and ankle exercises, and maybe to some extent something like an aspirin to reduce the risk of thromboembolism. You must manage osteoporosis. You are failing in your duty if you treat a fracture neck femur without treating the underlying osteoporosis. That is absolutely a must. And you can treat, I would have a reluctance to treat them with teriparatide because that's a 2-year course. But then the options like bisphosphonate, like the zoledronic acid injection is almost a rule in our setup unless they have the renal compromise. So this is a treatment algorithm. You can skip the upper side, which talks about non-union treatment with 3 stages described by Dr. Sandhu. But then if the patient is old, but physiologically younger patient, a high demand patient, you can do a total hip replacement. If the patient is more than 70, you can do a hemiarthroplasty. And this is how we choose between hemi and THA. Look at the patient, whether the patient is cognitively intact or at high risk of dislocation as a previous stroke or Parkinson's disease and all. So if the patient is cognitively and neuromuscularly intact, or he is not. If he is not, you should consider hemi rather than a total hip. If he is intact, then ambulatory and good life expectancy, you should go for total hip. If he is, doesn't have a very long life expectancy, you should go for hemiarthroplasty. And I'll finish this talk by this one paper by Mohit Bhandari's group, which was published in NEJM, and it should put a lot of controversy to rest, although these patients have only been followed up for 24 months. But this paper says that the total hip arthroplasty is comparable to hemiarthroplasty in a hip fracture. It doesn't offer much bigger advantage. The only catch, I think, is that a hemiarthroplasty fails because it either sinks in the femur, and if you cement it in the femur, it goes to the protrusio. Both the complications of hemi replacement occur because of poor bone quality. So if you are able to take care of the bone quality as well, you will see some of the hemiarthroplasty which are seen, you will see around you. Your boss did it 15 years back, and the patient is coming around walking and doing very well with the hemiarthroplasty. So that is the note on which I leave you. Thank you very much for your attention.
Thank